even if they did not favor the defendant. The defendant and her lawyers provided the panel with access to medical records and witness statements used in the trial. The panel self-determined how to examine the medical evidence, how to interpret the findings, and to produce a report independently. As chair of the panel, I issued the following instructions to the members of the panel. First, to review the medical records and determine the cause of death, in their opinion, or injury. Second, to review and comment on the expert witness statements and opinions.
So
and
they're
third,
reviewing
to
Lucy
provide an
Letby case.
independent report about the causes of death or injury. The methods we used was that each case would be examined by 2 experts independently, who then submitted their reports to me, the chair. If their findings were in agreement, their conclusions were accepted as final. If their findings differed, a third member of the panel was asked to review the case, and a consensus opinion was then developed. Summaries of each case were developed by the chair and approved by the panelists who examined the case, and then shared with the whole panel. Strict confidentiality was observed. I am the chair of the panel, and I invited members of the panel to participate on a voluntary basis and to work pro bono. Members of the panel, including myself, did not receive any benefits in cash or in kind, and even my trip here today is self-funded. The panel comprises 14 very experienced and well-known experts from highly prestigious institutions in 6 countries around the world, including Canada, the United States of America, Japan, Germany, Sweden, and the United Kingdom. They include 10 neonatologists, 1 pediatric surgeon, 1 pediatric infectious disease specialist, 1 senior neonatal intensive care nurse, and 1 other pediatric specialist. With the exception of myself and the member from the UK, the other members of the panel knew of the existence of the case, but otherwise had very little knowledge about it. I will give brief introductions to the members of the panel in a moment, and their biographies are in the summary report, so you can refer to it to see who they are. Okay. Now, today I will provide you with a summary of our findings. Copies are available at the side table, and you will be able to access them after this press presentation. The full report will be provided to Lucy Letby's barrister later this month. Now, the panel examined all 17 cases with which Lucy Letby was charged, and they are labeled patient 1 to patient 17. The cases involve a number of different allegations about causes of death or injury, which can be roughly grouped into 6 categories. First, air embolism caused by injection of air into the intravenous system. 2, splinting of diaphragm caused by injection of air into the nasogastric tube. 3.
So what they're doing now, right, they're reviewing, they said they had this new medical evidence that's come up against Lucy Letby's case. So what they're doing, they're reviewing it and telling you what is the causes that was done to the babies that she unalived or caused injury to. So that's what he's doing now.
3, dislodged nasogastric endotracheal tube causing collapse. 4, hypoglycemia caused by injection of insulin. 5, trauma to the abdomen or gastrointestinal tract. And 6, overfeeding. Now, in the interest of time, I will only discuss 1 or 2 representative cases from each of the 6 groups, because otherwise we'll be here all day. All reports, however, will be provided to Lucy Letby's solicitors. So I will start with each of these cases that I'm presenting today. It will be very brief because, you know, these cases are quite long for many of them.
Yeah, they are.
And if we had to go through all the details, we'd be here forever. I can tell you they took days and days and sometimes weeks to go through each case in detail. So we're going to give you the highlights of what happened, talk about what the allegations were in the conviction, and what did the panel find? So baby 1 was a case of air embolism. This was a preterm baby, twin 2 infant, who was born by emergency cesarean section. And he was well until the 2nd day of life, when he suddenly collapsed and had skin discoloration with blotchy patches of brighter pink on a bluey-gray background. And he did not respond to resuscitation.
Oh, wow.
The allegation was that baby 1 died from injection of air into the intravenous line, causing air embolism and resulting in collapse, patchy discoloration of the skin, and eventually death. So, to begin, I will give you a little bit of background on the publications of air embolism. The prosecution, in part, based their allegation on a paper that I had written in 1989, where I described all 57 cases that had been published to that point in time. And it showed that the babies would present a certain number of symptoms or signs, and also that about 10% of them had skin discolorations of different kinds. At that time, I did not distinguish between arterial and venous air embolism. And, in this particular case, the allegation is that she injected air into the venous system, into the veins.
That's deliberate.
So there's a difference between arterial and venous, because the arteries carry blood to the body to supply the organs and the skin, whereas the veins actually carry blood away from the organs or the skin to the heart and to the lungs. And in the new paper that I published in December of 2024 in the American Journal of Perinatology, a copy of which will be in the summary report that you will receive, we actually separated the cases with arterial venous air embolism from the cases with venous air embolism. And what we found was that in the cases where air was injected into the veins, there were no cases of patchy skin discolorations ever described in the literature. So the notion that these babies can be diagnosed with air embolism because they collapsed and had these skin discolorations has no evidence in fact, right? None of this actually has ever been described. If this is true, it will be the first case ever described, but it's never been. And there's a reason for that. The reason is that in the arterial system, when you inject air into the arterial system, it goes directly to the skin or the blood vessels or to the organs. Whereas in the venous system, it has to go to the lungs first. And the lungs has a complex bed of very small blood vessels that filters out all the air bubbles if they come through, so that they don't actually get to the arterial system. Now, in newborn babies, there's a hole called the foramen ovale in the heart, which can allow the blood to actually move over to the arterial system. But it has to go against pressure, because the pressure in the arterial system is higher than in the venous. And so what we found in the literature was that there were no cases that have been described where, in fact, these skin rashes have occurred. So let's do away with that theory, all right? The notion that these cases are air embolism because they collapsed and because there were skin rashes has no basis in evidence, okay? Let's be very clear about that. Now, so what can be the possible causes then? Why did this baby suddenly collapse? So we went into the history of this baby to see what actually happened. So in this baby, the mother had antiphospholipid syndrome, which is a condition in which the immune system mistakenly creates antibodies that attack tissues in the own body. Now, these antibodies can trigger blood clots to form in arteries and veins. And during pregnancy, these antibodies can pass through the placenta to the neonate and lead to thromboembolism, which means clotting in the baby. Particularly happens if there is concurrent infection. Now, post-mortem of baby 1 showed that there was a recent non-occluding thrombus in the liver, which means that in fact there was a thrombotic event that happened in this baby after the baby was born. On the day of the collapse, the baby's IV tissued at 1600 hours. Tissued meaning that the IV that was supposed to be in the vein somehow penetrated the vein and came out into the tissues. And so the infusion was not going into the circulation, was going into the tissues. And so the air was getting swollen because the infusion was coming out. And so because of this, they removed the IV and replaced it with an umbilical venous catheter. But the first insertion was malpositioned, and so they had to replace it again. Later on, a long peripheral line was then inserted at about 1900 hours. Now, they then took an X-ray, etc., to make sure it was in the right position, and eventually the infusion was restarted. But the infusion was restarted at 2000 hours. So there was a period of up to 4 hours when these lines were in, but there was no infusion. Now, here's the problem. Even in a baby without any problems, we avoid putting lines in without infusion. because if you do that, clots can form on these lines. In this case, the baby actually predisposes to clot formation because of the antiphospholipid syndrome. And therefore, to have lines in there for 4 hours without infusion is a risk. All right. Now, what then happened was that minutes after the infusion was restarted at 2000 hours, baby 1 collapsed. It is most likely that there was a thrombus that formed on the tip of the catheter that then dislodged when the infusion was started, and it migrated to an artery supplying the brainstem, causing sudden collapse and inability to resuscitate the infant. It is also possible that baby 1 had placental fetal vascular malperfusion. So what's that? That's a condition in which the fetal villi in the placenta present small thrombi that can travel to and occlude small blood vessels in major organs like the heart, brain, and liver. And if a small thrombi lands in an artery supplying a critical structure like the brainstem, it can also cause sudden death, and they are very hard to find on post-mortem because these vessels supplying these critical areas of the brain or the heart are very tiny. And so all you need is a small thrombus to occlude it. When you're doing a post-mortem, you're doing cuts to see whether you see anything. And you have to actually cut exactly where that thrombus is in order to identify it. So just because a post-mortem doesn't identify it doesn't mean it isn't there, right? And in the second condition, which is fetal vascular malperfusion, these collapses can occur 1 to 2 days after birth. So one of these 2 causes probably caused it, and we think it's the first one because of the temporal relationship with the lines that were inserted, the predisposition to formation of clots on these lines if you don't infuse it, and then the occurrence of the collapse just minutes after the line was re-infused. So our conclusion is that baby 1 died from thrombosis and that there was no evidence of air embolism. Because in this baby, the allegation for air embolism was that number 1, the baby died, we could not find a reason for it. Number 2, this baby had this collapse accompanied by these skin discolorations, which was consistent with what the allegation was with air embolism. And what we are saying is, first of all, the second reason doesn't hold, because air embolism by the venous system does not produce these kinds of skin discolorations. Number 2, there is a plausible and reasonable reason why this happened, which is what I just explained. So for both those reasons, we feel that this diagnosis is wrong, that this is not only air embolism. In fact, this is because of thrombosis.
It's very far.
Now, the next baby, I forgot to show you that, but hopefully you understood what I was saying.
It's very far.
The next baby is baby 4, which is another case of air embolism. Now, baby 4 was a term baby who was born by emergency C-section after prolonged premature rupture of membranes. She became pale and floppy at 12 minutes of life and required resuscitation. She continued to have respiratory distress afterwards. She was then admitted to the neonatal unit, and continuous positive airway pressure support for the respiratory distress was started, and antibiotics were started, but only 4 hours later after the baby had been admitted to the NICU. The chest X-ray showed pneumonia. On the 3rd day, the baby became mottled, had dark brown and black tracking lesions across the trunk, and 2 evolving purpurate-looking patches on the abdomen.
Oh, wow.
She had repeated episodes of apnea and desaturation until final collapse and death.
Oh,
now, the allegation is that baby 4 was a stable baby after the baby was born and admitted to the NICU. And then on day 3 of life, the baby suddenly collapsed. And that this was due to injection of air through the intravenous system, causing air embolism, resulting in patchy discoloration of the skin and death. Now, first of all, I would like to just repeat what I said earlier, that there is no evidence that air embolism through the veins results in patchy discoloration of the skin. So let's just dismiss that, all right? That's not a consideration. So what could this be? Well, first of all, this baby was born after prolonged premature rupture of membranes. What it means is that all the babies in utero have a membrane around them that protects them.
Yeah.
And if the membrane is ruptured, infection can ascend.
Okay.
Also, membranes often rupture because of infection. So for that reason, there is a standard treatment guideline in this country and in other countries that if there is prolonged premature rupture of membranes, the mother should be given antibiotics right away so that the baby can be protected from any infection. In this case, that was not done. The mother did not receive antibiotics. Second, there were important delays in the admission, diagnosis, and treatment of the baby after the baby was born. The baby was admitted to the neonatal unit only 3.5 hours after birth, at which point she was noted to be cold, blue, dusky, and in respiratory distress. She had polycythemia, which means that she was looking very dark in color, and she had infection because the blood test at the time showed white cell count that was very high and a neutrophil cell count that was very high, which are all indicators of infection. So there was a long delay in admission and treatment. Now, don't forget the antibiotics should have been given a long time ago during the labor itself.
Yeah, to stop it, to stop the infection from spreading. I get that.
Half to a full day or more,
Yeah,
where the baby was not receiving antibiotics when in fact there was already infection. On top of that, the blood
treatment
gas
wasn't given.
that should have been taken to see how the baby was doing was not taken until after 4 hours after birth. And then when it was taken, it showed very high carbon dioxide and respiratory acidosis, meaning that the baby was in respiratory failure all this time, and nothing had been done for 4 hours. The continuous positive airway pressure support for the baby was again started nearly 4 hours later after birth, despite the baby having respiratory distress. Now, she was eventually electively intubated, but 3 attempts were required before she was actually intubated and ventilated. And these delays subjected the baby to unnecessary acidosis, high CO2, and delay of antibiotic treatment. This was not a stable baby, as alleged by the prosecution witness. And in fact, this baby continued to deteriorate for the next few days until final collapse, with worsening symptoms of infection as we went along. So let's see what happened. So she was admitted, and as I said to you earlier on, she was already sick on that day. On the following day, she developed fever. She had intolerance when the CPAP was removed. In other words, she could not tolerate coming off the CPAP support. She had continuing deterioration of blood gases over the next day. She had increasing metabolic acidosis. All these indicates that the infection was in fact getting worse. The baby was not stable. And then on the next day, on day 3, she further deteriorated with rising CRP. Now, CRP.
So treatment wasn't given like during birth and after birth. So instead of them stabilizing her condition worsened like by day 2. I think that's the baby. I forgot the letter they give her, baby. I forgot the letter, but they didn't stabilize the baby while she was in incubation in the NICU to make sure she was good. The first baby, there was a problem with the membrane around the baby, so the membrane was rupturing. The mother didn't get the antibiotics given, and when the baby was born, they didn't continue the treatment, and then the baby deteriorated. And one of them, their color changed. The color changed, and then the baby deteriorated. So they're saying, so what they're doing new medical evidence on the Lucy Letby of how these children might have been unalived, etc. So he's going through a list of all the forensics and what they found so that they can establish what exactly happened to the children.
CRP is the test we do to see whether there's infection. And if the CRP is going up, it means the infection is getting worse. If the CRP is going down, it means it's getting better. And this was going up. There were repeated episodes of apnea and desaturation, again indicating the baby was clinically getting worse, not better. She then developed prolonged coagulation times. Coagulation times means how long does it take for your blood to clot? And normally, for all of us, it should clot within a certain period of time. If it takes longer than that, it means that there's a coagulation defect. Something is wrong with your blood. And in this case, the coagulation time was increased. Now, this is a serious development because it indicates that the infection is going out of control. Most of us, when we are infected, we are sick, whatever, the coagulation time will change. But if the coagulation times change, it means that this baby is going into what is called disseminated intravascular coagulation. And this is a condition that appears when a baby is severely infected and severely ill, because it causes spontaneous coagulation of the blood throughout the whole circulatory system. The blood just starts to clot everywhere. And as it clots, it consumes the coagulation factors, and that's why you see a coagulation defect. And then that leads to spontaneous bleeding in all the organs and elsewhere in the body. So when you see something that's starting to cause coagulation defects, this is in fact an early sign of DIC that is developing. And so the blood vessels in the skin are compromised, because if you have clotting in the blood vessels of the skin, they compromise the blood flow, which together with hypoxia triggered dilation and contraction of small vessels in the skin, which then results in the skin discoloration that you see, and tracking lesions and so on. And she ultimately...
So what he's also doing is the pathology of each baby as well. So like, you know, to every single dilemma of the baby that they went through, like what you just explained about the blood clotting, the different medical references, because these are all pathology phrases and what could have been done to prevent the child from being unalive, basically. Like the discoloration of skin, which is mentioned quite a lot, the blood clotting, and there's another one that he said too, which I've forgotten right now. But anyway, let's continue.
Collapsed and deceased. So this baby died of systemic sepsis, pneumonia, and disseminated intravascular coagulation. The mother should have received intrapartum antibiotics prior to delivery.
So
there was delay in recognizing respiratory distress after birth.
So they're saying it's also down to the mothers not getting treatments as well, why the babies also passed as well. So that's the examples he's saying. That's why they're saying they're doing checking the new medical evidence that is placed regarding to Lucy Letby.
There was delay in starting antibiotics and delay in starting treatment for the respiratory distress. We did not find any evidence of air embolism. All right. Now the next baby is baby 9, where the allegation is that the baby received nasogastric tube air and then subsequently was also given air through the IV into the intravenous system, which caused air embolism. Now, baby 9 was a preterm infant with intrauterine growth restriction, respiratory distress syndrome, and chronic lung disease, who had repeated episodes of apnea, desaturation, and bradycardia, needing resuscitation during the hospital stay. And the baby was in hospital for quite a period of time. The baby also had an episode of lung collapse, and reports that there were thick gelatinous airway and oral secretions. And one of the registrars, who is a mid-level doctor in the NICU, stated that it's not unusual for babies on breathing support to get secretions, but it was a bit unusual for them to be so stubborn at being removed like in this baby. And after each period of apnea and desaturation, they had to resuscitate the baby using bag and mask ventilation, and then the abdomen was distended. And abdominal x-rays taken after that showed gaseous distension of the intestines. At 2.5 months, she had an episode of severe apnea, bradycardia, desaturation, and heart block, and then deceased. So it was alleged that air was injected into baby 9's stomach through a nasogastric
each and every single one of them,
leading to recurrent episodes of abdominal distension, which then splintered the diaphragm and caused respiratory arrest and failure, needing resuscitation. It was also alleged that on the 13th of October,
if I don't complete this one, I'll come back and do another one on this,
resulting in delay
to update
and
my thing
response
on Lucy
to a collapse.
Letby.
And then on the 15th of October, air was injected into her intravenous tubing, causing air embolism and death.
There's 17 babies in all. 7 babies.
So we looked at this case in detail.
And 7 babies.
And what we found was that baby 9 was a very preterm baby with intrauterine growth restriction, respiratory distress syndrome, and chronic lung disease. Also, that in fact, surveillance cultures, which are normally done after a baby is admitted to the unit from outside, to make sure that there are no dangerous bacteria being brought into the NICU. So they routinely culture all these babies after admission. And in this case, the surveillance culture revealed a bacteria called Stenotrophomonas maltophilia, which is a gram-negative bacteria from the endotracheal tube. And the doctors in the unit were duly notified that that was the case. Now, this particular bacteria is unique because it is a multi-resistant opportunistic pathogen that can colonize the airway in biofilms that are resistant to antibiotics and impossible to clear in patients with chronic lung disease.
Because it's a lot of paperwork that he's going through. I'm going to try and find what he's talking about, and we're going to take a look at it, right? And we're going to get back to this live because he's saying a lot. He's saying a lot of good information. I think people should know about these information, especially if you are a mother who's been in this, if you know people who's been in distress during pregnancy and all sorts of stuff. It's good to know the pathology of some things, because when you know, then you know what's going on. Like, you see, like how they're saying that how the babies was given air and certain stuff, the babies look discolored, I mean, and all this. So there is a lot of details in this stuff what he's talking, because they look like they've done forensics on them again. They've gone back and done forensics and checked on them again. So he's come back with the findings, to what the findings he have found. So hopefully this will still be up by the time I get to it, because I feel that I need to talk about, I've always spoken about Lucy Letby's case. There's me and a few other people that's spoken about it, and now it's gotten to another phase in the case. It'd be interesting to hear, because I do believe she caused some kind of something on a live in, you know what I'm saying? So at the end of the day, right, even the findings is interesting, where like there was no compression given to babies and certain stuff that was lacking, right? You know what I mean? Like when he mentioned the one about the mum not having the membrane around the baby to protect it, when really whoever the nurse or midwife should have given her, or they say antibiotics or something to protect the baby, or and even after birth there should have been another treatment to make sure that the baby survived. And I think what they're trying to do is they're trying to take Lucy Letby out of this situation again, because remember, she's been trying to appeal for a while. She's been trying to appeal for a while, trying to come out or whatever. And yeah, so I'm gonna leave it right here, because I'm holding this phone and my hand's hurting. It's better if I do it the other way, because then while they're talking, I can go look into and see I can pull out some stuff so that we all can understand what's going on. I know there is some NICUs people in my audience who works with babies in NICU, etc., etc. So I know they understand some of the words that is used. So with that said, I'm not going to keep this for long. I'm just going to leave it right here, and I'm just going to update my Lucy Letby playlist, and I'm going to probably do it tomorrow, probably, if I'm not sidetracked by something else. And I'll see you soon. Take care. Bye.